Hello, dear colleagues, and it's my honor, and we can share some cases and maybe discuss about how about some new treatment for coronary calcification. And this is today mainly we'll talk about IVL balloon. So, and we can. So we can see some epidemiology. We all know the calcification is the most difficult part of the routine coronary intervention, and some studies showed maybe around 1/3 of the patients have midnight to severe calcification, and this is from two study and showed similar result. One is the account 30.8. One is the 26 plus 5.9. So, and for quite a long time, and nearly maybe 30 years or something, we most time we use the rotablator. But recent several years, there has some improvement. We can use the modality of the IVL. And so basically, for it's some progress, and because the classification usually is difficult to deal with, we can induce some lots of complication. We cannot, if maybe the stent cannot go through, or even can pass the lesion, but the difficult expansion. So under expansion also leads the resources, sometimes even worse with acute and subacute thrombosis. So this kind of the calcification is really our PCI, the enemy. So we have to deal with it, and most time we use the intravascular imaging like IVOS or OCT, and to see more clearly or more sensitive to detect the calcification compared with the routine just used angiograph. But angiograph also, if we can see still frame, we can see the calcification very clear. Usually the means it very severe. But sometimes only can in the for moving picture we can see the calcification is maybe moderate, but it's not sensitive. So for intravascular imaging, we can classify the classification with superficial and deep classification. But the most the superficial classification is mainly our enemy to deal with, especially some cathar noodle. In recent some research, the cathar noodle is most difficult part to deal with. So far, with even we have now the rotor, the IVL, the laser, the NC balloon, the cutting balloon, lots of different modality, and also but not in my country, but in other countries, they have the orbital, the some kind of the devices. So this is the some background, and also the for lesion type. So this is for anatomy, and the lesion type is the patient with the ACS and left main and CTO, and this is also can we may see the severe calcification. And in recent published Chinese expert consensus on the diagnosis and the treatment of the coronary calcification, and IVR is to be is a very good system. It's safer and effective and simpler than the other technique, and the number of cases reports with use in more challenging calcification is also increasing. including acute coronary syndrome, unprotected left main, CTO, and insufficient stent dilation. So IVL now is the only effective on superficial calcification, but also the only technique has a therapeutic effect on the deep calcification. Because of course, for deep calcification, it depends how deep is it and how big the vessel. We also know that some adverse calcification, the score published by one Chinese doctor working in the CRF. So we may see two cases, and just to from case to introduce how to use the IVL. This is the 65 gentleman and intermediate chest tightness accompanied burning sensation behind the sternum for 3 years and aggravated for 1 week. The patient began to experience intermediate chest tightness accompanied by burning sensation behind the sternum 3 years ago, and 1 week ago the patient had a recurrence of symptom without obvious cause and was treated in a local hospital. The examination showed the TNI is positive. The patient was diagnosed with non-ST elevation, acute myocardial infarction. And then patient had angiograph. Angiograph, this is the result. We can see the angiograph. So this is when patient have the hypertension and no diabetes and no other chronic diseases. The patient quit smoking 18 years ago, but still drink alcohol for more than 30 years. So this is a non-ST elevation myocardial infarction and hypertension. And the routine test and ECG, not so much abnormal finding. Only the TNI is positive. And the echo showed the basal segment of the posterior inferior wall of the ventricular was weakened, and the other diameter is nearly normal. Ejection fraction is 59. And this is also ultrasound result. Not so much difference. So we can see the angiograph. Angiograph, you can see left main and LAD and also the RCA and very diffuse lesion, and the PRA is the most severe part. So this is no, this is so this is what's wrong? So this is the classification. The IVOS. From the PRA, the pullback. And we can see this is grade 4 classification with 270 to 360. Based on the IVOS score, it's 3 points. Because this is a relatively big vessel, or maybe even we can see the 4 points, because we didn't see clearly the cardiac noodle. So it's 3 points anyway. And this is the still picture. We can see 360-degree classification, and this is the position from the angiograph and the IVOS. This is 270. So this is the because we think RCA is this time the culprit lesion. This is non-ST elevation, and from the echo, we show maybe this is the culprit lesion. So with the 6 French AL 0.75 guiding, and use the routine cyan blue guide wire for the PDA and the PLA, and the RCA was pretreated before I was with the 2 balloon and 2.5 balloon and NC track NC25 balloon, but still we can see the with the sign it's not fully expanded the balloon. So based on the angio. So we decided to use the IVL to treat this part of the calcification. We used the 2.5 IVL balloon and with 3 release cycles, and the total pulse is 30 times. Used so I was the pre-check, and after the IVL, we checked the I was again. So and also use the scoring balloon after the IVL, and 2.5 by 15, and the NC track 2.5 by 14 atmosphere, and from distal to proximal. Looks the angiograph showed the balloon, the expansion is better than before. And this is the after predilation, and this is the angiograph. So we then still even we use the IVL, we think maybe have a good preparation of the distal part calculation, and it's difficult to implant the stent. So we use the Godzilla and to help to from PLA distal and to proximal we implant 2.25 and 2.5 and 3.0 and 3 stent. And finally, the proximal part with 3.0 and 3.5. So from very distal to the very nearly the orifice, totally we implanted 5 stent, drug-eluting stent. So this is the angiograph result after we implant 5 drug-eluting stent. So this is the case 1. Unfortunately, and we didn't get we lost the final IVOS result. Of course, we should check the IVOS and to check the expansion result, but angiographically it looks acceptable. And we then see the other case. And this patient is a 6'9" gentleman, also admitted hospital due to chest tightness and shortness of breath. after repeated activity for more than 4 years. So the routine test is the NT-BNP is higher. So other blood test also the urea is increased. Glomerular filtration rate is down. This is the patient, the angiograph showed severe calcification in multi-site, 90% synthesis in the distal end of the left main. It's also very challenging case. And also the severe calcification throughout the proximal and the middle segment of the LAD, with the most severe part in the first diagonal, 90%. But still the blood flow is TIMI3, and also 90% synthesis in the orifice of the circumflex, and also 80% in the proximal and the middle segment. Also TIMI3 flow. This is it's really a very challenging case. And this is the spider wheel. And also we can see the RCA, we can see the stent, but not a severe synthesis in the main part. But PRA is a severe lesion with 80 to 90% synthesis in the PRA. Also, the patient had poor cardiac function. So because the angle of the left main and the LAD is nearly 90 degrees, so usually for this kind of the sharp angle, if we do the rotor ablator, it's a little dangerous. So because patient refused to do the cabbage, and also some contraindication for the cabbage, so finally the heart team decided still to do the PCI. But with the wire and some rotor wire change a little the angle from the 90 degree to not very sharp. So still we use the 1.5 bird to do the rotational atherectomy on the proximal and the LAD and the left main, and also to the middle LAD. So after left main LAD, we do the rotor atherectomy, and we also do the same bird to do the orifice of the circumflex with 180,000 RPM. And this is the after the ablation, and we check the IVL from the distal part. So the very distal is okay, but the vessel is small, it's increasingly bigger and with some calcification, but not very severe. But I was going to the middle part, still not very big, and the diffuse lesion. And also we can see some calcium noodle, eccentric lesion. Now the vessel relative bigger from 2.0 and to 2.5, 3.0. Also some eccentric calcification. So really, really diffuse lesion. Here is the most challenging part, but we can see some crack, but the calcification is around 300 degree. And also we can see some dissection and reoperation after rotor atherectomy. So it's a lung calcification lesion. And we didn't see 306 degree, but really see some around 270 to 300. But after rotablation, we can see some crack, dissection. We can see the branch wire coming from 1 o'clock. This is the proximal part. The vessel is bigger. So finally, we reached the left main. But because this is really a long diffuse calcification lesion, so we still think and this is left main bifurcation. So the expansion is very important for this poor patient. So we use the IVL balloon and to treat LAD and the LC second flex with 3.0 and 2.5, the IVL from the Liverpool company and West Crack, and to do the again after rotablator to do the lesion preparation. So after the preparation and predilation, we still use the routine technique for the bifurcation. Because the dilation of the orifice of syncflex is acceptable, so we use the long drug routine balloon 2.5 by 40 millimeter to treat the middle and proximal circumflex for more than 60 seconds. And then we implant the 3.0 by 33, the drug-eluting stent in the proximal and the middle segment of the LAD with the guide wire to protect the first diagonal. And we use the called the balloon protection technique to use the 1.5 by 15 routine balloon in the orifice of the diagonal. and sometimes we implanted the stent, and also after we be sure the diagnose is okay, and we implant the 40/20 drug stent from the proximal LAD to the orifice of the left main. And with 30 NC balloon and 40 NC balloon to separately post dilation the LAD stent and the left main stent. This is the final angiograph, and the second flags showed still some restenosis, but not severe. It's maybe less than 30%. And the TIMI flow is good. Left main LAD showed no adverse residual stenosis. And also we checked the final hours from the LAD distal part. So actually we can see the vessel is a little bigger, and maybe some tiny dissection in the distal part of the stent, but not severe. So far the serial stent expansion is okay. Also, we can see the eccentric calcification still make the stent is not in circular. So far, the serial stent and the full stent, the expansion is acceptable. So the stent not cover the orifice of the left main, but the orifice of the left main is no severe lesion. So just introduce these two case. So after this presentation, maybe we can talk and make some discussion about IVL. Also discuss maybe about how to treat the classification lesion in right now the area. Thank you for your listening.
Okay, thank you for Professor Qian for the excellent presentation. And next we will move into our discussion part. Please feel free if you have any question about the IVL technology.陈哥，咱们医生这边有什么问题吗？
是我在问，我搞我意思吧 Bruce, Andrei, Evgenia. Karai. 他们这边没有回复，就说明他们没有问题。要不问问那个朱莲？
好的，朱莲，咱们越南医生这边儿。
Hello. Is there any questions from Vietnam doctors? Dr. Qian? Hello? Any questions about IVL or about the cases? Just you can ask Professor Qian. 好像我这边好像也没有，不太，
没有问题是吗？
主任，我那个他们因为这个他们俄语嘛，他就跟我说让我在群里面帮我问一下关于第二个 case 的，就是说就是我们就是有没有考虑过 LCX？ 关于第二个 case。
LCX what for what？
就是支架嘛，有没有就是需不需就是放支架放到
stent
有没有考虑过？
Of course, if the circumflex after predilation, if we see severe how about the dissection and hematoma, or the flow is not good, or the preparation the lesion is not good, we of course we will implant the stent. But after rotor and IVL, the circumflex angiography and adverse check, no severe dissection. So in that way, for this very tough case, we don't want to implant too many stents for the left main bifurcation, because lots of studies show the two stent strategy, no matter DK, DR, and culotte, or any technique for two stent, still have a very high restenosis rate, especially in the second orifice of circumflex. So in China, lots of physicians like to do the crossover technique, provisional technique for left main LAD stenting, and use the DCB to treat the circumflex. But of course, if the severe under the residual stenosis is very high, will implant the stent. Also, we have some Chinese technique. We can, not this case, but we have several experience for implant stent just near the orifice of the circumflex, and use the DCB to cover the real orifice, and then use the LAD left main and crossover technique. In this way, is very easy to do the final casing, or sometimes even we don't need a final casing to treat some difficult bifurcation lesion.
好，谢谢主任。我那个一会儿把您的这个说的这个情况直接翻译给他们，然后因为他是通过后台给我问的。然后另外就是还有一个问题，这是来自于那个圣彼得堡那边，他就说我们就中国这边是如何选择这个患者，如何评估他的就是这种有效性，如何选择这个工具。然后呢，还有一个问题就是 IVL 会取代 NC 的这个球囊吗？在 IVL 之后是否还需要 NC 再重启一下，然后才能够放支架？就是这是第二个问题。第三个问题就是说想让您分享一下就使用 IVL 的这种经验。
我就记不住了啊，你一会儿。
行，那我来问第一个。第一个就是说您在就是怎么说您 IVL 的话，你如何选择患者？你如何评价？就是根据在什么样的情况下你会选择使用 IVL？
A good question. So usually we have several modality. I told for quite a long time we just use the rotablator because it's the only modality we have to deal with the severe calcification. So usually after rotablator, we will routinely use the NC balloon, but sometimes we use the cutting balloon or scoring system to modify to make the crack more deeper and make sometimes after rotor we can make more crack anyway. So how to want to use IVL, because IVL usually if very severe and IVL have the difficult to crossability. It's the one of the IVL limitation. So how to say, if you cannot cross the lesion, even the IVL is more safer and easy to use, but it cannot reach the position. So in that way, we have to do the small balloon dilation, or sometimes still we have to use the rotablator to have the pathway and then use the IVL. But IVL, my experience is usually is relatively safe and easy, and in that way we don't use the bigger bird anymore. Not anymore, but not less and less, and we can use the if very tough lesion, we use the rotor and IVL like the second case, and combine, especially IVL very effective for the proximal part and easy to reach part, this kind of the calcification lesion. And the question is also about IVL and the NC balloon, right? It can replace the NC balloon, right? This question. The other. So my answer is how to say, I don't think it can replace NC balloon, because several reasons. One of the basic reason is the IVL is much expensive than NC balloon, right? We cannot use the IVL to do the routine every case preparation, also the post dilation. So NC balloon still is our very friendly, and most of the time we will use the first choice, the modality to deal with the calcification, especially some moderate intermediate calcification lesion. So I don't think it can replace. 还有什么问题？
那个主任，就您刚刚说的，我想再问一下，因为您提到的那个 severe calcified lesions will use combine the rotational balloon and the IVL together, and if this place is really severe, can we use the mini balloon or use the microwave casters to get into the vessels first and then use IVL instead of rotational?
Well, very good question still, but I hope the lab company can make the better and better IVL balloon, have a better crossability. Usually, like that second case, the left main calcification bifurcation, very difficult, and after because the smaller balloon even very difficult to cross, and even cause it difficult to fully dilate. So not fully dilate, you cannot cross the IVL. So still crossability is the most, to me, I think is the most limited part of the IVL system. So anyway, if you can use, but also some challenges if you use the small balloon to dilate calcification lesion. Sometimes it's okay, but sometimes if you use very high pressure, even you can pass, for example, to a balloon, NC balloon, but use very high pressure. But if you not achieve very good result, you will, but you sometimes you will make some severe dissection. So dissection may influence the flow, and the patient have chest pain. So at that time, no matter you use any modality, you will face the difficult part. So we should combine and balance to deal with, because each severe is the general word, but it means lots of different situation, different patient, different part, like left main and orifice LAD and orifice RCA, and also so I can understand your meaning. Of course, we don't want to use the rotor very routinely. If we can use, like you said, the small balloon open and IVL follow, that's good. But but usually that means the lesion, not means the really severe. So severe is still general word, including the different situation, like we call the IVL score, OCT score for the classification. Still, even we have a 3 score right now, but lots of physicians think this score cannot really represent all the classification lesion, because this score just comes from the intravascular imaging, but this imaging can pass the lesion, so we can get this score. It means it's not a really challenge case, like second case. Second case, you cannot pass the even small balloon. You cannot pass the IVL, so you cannot get a score. You cannot. So this score cannot be used for this region. You have to have the make your modality like IVL can pass. So that's what I mean. Rotor plus IVL.
Okay. Thank you for your answering. And I just want to know if how many proportions of these severe calcified lesions can take up in the whole surgery or cases among the IVL? The proportion, like 20%, 10%, like that.
It's difficult to answer, but still, of course, it's very easy to answer is for severe lesion, and right now the IVL is for my practice is increasing, but still, because some money or some price and some discount also is also another limitation, and for real world, I mean. So but if it's like maybe the question asked is not so expensive, and of course it's easily being used, and also if may have more evidence of the, for example, the RCT trial can show the can benefit the classification patient have the better immediate and long-term clinical result, and we will use more and more and IVL. But anyway, IVL is a big progress. It's for deal with the many classification lesion. We can easily to use, and not to do so complicated procedure like the rotor.
Okay, thank you for your answering. And I still have another questions. For example, the vessels, they're already stand in it, and also combined with the calcified lesions when we use IVL. Maybe how many times do we need to release the pulses that can destroy the calcified lesions and won't do harm to the stents in the vessels?
Yeah, it's good question. And so far, the IVL don't have the indication of the after implant stent and to treat the under expansion so far. But I knew some study is ongoing to do and to try to verify. And but I can tell you it is effective modality. But we don't know it will hurt the stent or hurt the polymer. I don't know. And it will influence the long-term result. I don't know. But for several cases we did. And so, I mean, the not good, some young physician, not good predilation, but very rapidly implant stent, and the stent underexpanded with the severe calcification. And so in quite a long time ago, we have to use the at least 2 or 3 burr to do the rotor. It's a very dangerous case and a tough case. But so
Yes.
far, after that era, we have the laser, and the laser can do some good thing. But recently we have the IVL, and the IVL also can do the good thing. Anyway, we most of cases we solve the under expansion problem immediately after. You mean the rapid how to say the just after stent implantation and use the IVL. Most of case we cannot see very good result, but usually the solve the most part of the underexpanded.
Okay, thank you. And陈哥，您刚刚不是还有问题吗？您可以先继续问一下主任。
主任，我这边是个小问题，就是也是来自于俄罗斯的，他就说，就是我们进行这个碎石的时候，使用 IVL 的时候，就是只是造影是否就够了，还是说还需不需要 IVL？ 他只是个小问题。
这也不是 ，it's not a small question. It's a big question. So how to say? And from the Chinese consensus, also from the European consensus, also from the American consensus. So each consensus or some guideline recommends to use the intravascular imaging to help to deal with the severe calcification lesion. No matter other modality you use the rotor, you use the IVL, you use the, of course, if not very severe, and I think just the calcification and the balloon and not expanded well, and use the IVL, and after IVL expand well, and we of course you can use the another NC balloon to verify it again, and the implant stent. If just a very short and lesion, it's okay. You don't use the IVOS OCT, it's okay. But for quite a long diffuse like bifurcation and the left main, you know the European and America and the Chinese the guideline for the PCI, and both recommend the intravascular imaging for the 1A indication. So for severe lesion, I think this severe lesion also not only left main and the bifurcation and the lung lesion, but lung lesion also I think should include calcification, because our calcification can combine with the left main, can combine with the bifurcation, can combine with the lung lesion. So to me, I think if you have the how to say if very so I recommend to use to imaging.
谢谢主任。
主任，
我目
我这边
前没有收到别的问题。
主任，我这边之前还遇到过有个医生，他可能the first time to use IVL, he has a question about the exchange liquid in the balloon, and normally we say that when we release one pulses and one cycle 10 pulses, we need to exchange the liquid in the balloon. So in real case, should the doctors change after one cycle is necessary needed, or we can do 2 cycles and change the liquid like a deflate the liquid in the balloon.
I don't understand your question anyway. But after preparation, it's about one time we 10 seconds for 10 times the pulse release, and then usually we change the position a little and do again. I don't understand your real question.
我可能没讲清楚，就是咱们在每一次释放完一次脉冲之后，1个周期之后，都是正常来说是要换一次球囊内的液体的，就是要撤压，就是 deflate。但是实际上真实的时候，我们是每次释放过一次之后都需要再换一下里面的液体吗？还是说会有
这不是要换液体？No. This is we don't change the liquids. We just inflation the deflation. This is for balloon. The deflation not change the liquid.
Okay.
I think you made some misunderstanding for the meaning of his question or her question. I don't understand. Yeah. It's a balloon. It's a balloon. Just a balloon.
Okay.
No matter no. Just with the can do the it's just a balloon.
Okay.
So we deflate for rebuild the blood flow in the vessel. That's our purpose.
Yeah.
Okay.
Yeah. Because you cannot long time. You will patient will have chest pain. Sometimes valectomy quite a long time, and the patient even have the ventricular fibrillation. It's dangerous for quite a long time if you go on.
But when we're using the IVL, after we release the pulses, there may be some bubbles in the balloon. That may be caused like decrease the effect of the IVL. So
yeah, that's true.
Yeah. Well, when we deflate the balloon, at the meantime, the liquid will be exchanged at the same time, right?
Sorry.
When we deflate the balloon, at the same time, the liquid in the balloon will be like change.
You mean you found the bubble? You already found the bubble, right?
Yeah.
Yeah. So if you found the bubble, you should maybe do some maybe do the preparation. If very big, you should do the preparation again.
Okay.
But anyway, the recommendation is you should do very good preparation. It's very important. So you should learn the tip tricks for balloon to with fully with the liquid, not so much bubble inside.
Okay. Thank you for your answering. Okay. Is there any other question?
我这边没有了。
还有一个是我自己的一个小问题，就是我之前了解了一下，如果病人体内有起搏器或者说有其他的就 pacemaker 这种的话用 IVL，遇到这种情况，比如说需要观察什么样的情况下要立即停止使用，或者说还是能继续使用的？也因为起搏器它有的也许可以兼容，或者是这个。
You mean the IVL have some the pulse can influence the
pacemaker.
Electricity of the pacemaker. So I don't have so much experience, but but usually I did one case, but I did only some premature pulse, but not severe and the some like tachycardia. So but if something happened severe, of course you should stop. But in this way, usually I don't think. I don't know. You can read some. I didn't read some any paper and report very severe effect. I don't think so, because we can stop if something happen, right?
Yes, it's like that. Thank you for answering.
Okay, so we're about to going to the end of today's forum, and a heartfelt thank you to Professor Qian for leading our discussion and your excellent presentation. And thank you to our international guests for joining us across time zone, and to all of you for your active participation and thoughtful question. Thank you again, and have a wonderful day ahead. Goodbye.